All right. So welcome everyone. Thank you for joining us tonight. Tonight we're going to do a little bit of Q&A after I go through how to read your own labs like a pro. So I'll go over two different types of reports. One will be the Quest/Cleveland Heart Lab panel, and then I'll go over the Boston Heart Lab panel, which today was the first day I had a patient come in without the results of the Boston Heart. So this is the traditional panel from Cleveland, where it's all color coded, and usually all the advanced lab companies use the same format. Green is good, yellow is borderline, red's high or low depending on what it is. And mostly concerned tonight about going over the inflammatory markers and the lipid profiles. So inflammation is really the key to cardiovascular disease. The more inflammation you have, the more your arteries are on fire, the more likely things are going to get damaged and plaque is going to continue to build up. So if anybody has seen my previous documentary on Amazon Prime called Uninflaming, one of my patients, Angela, had some significant health concerns and an autoimmune condition. She was very inflamed. With the help of myself and a couple of other providers, she was able to reverse her chronic diseases, get off a lot of medications, and is doing very well today. Is actually now a health coach and making documentaries about different people's health journeys. But you know, inflammation was the main thing that I was tasked with talking about in her documentary. So if you haven't seen it, it's on Amazon Prime, named Uninflaming. But inflammation. So they always put it, first on most of these panels because again, this is one of the most important things. So myeloperoxidase is an enzyme that's specific to plaque. So it's elevated when there's more likelihood plaque is going to be developing in your coronary arteries. Myeloperoxidase is an enzyme that when it's high also inactivates HDL. There's no such thing as good or bad cholesterol. We'll talk about it in just a minute, but HDL, one of its jobs is to take cholesterol back to the liver to recycle it. If myeloperoxidase is high, it damages the HDL, so the HDL doesn't actually function. So you can have, quote, high HDL, and people think, oh, I got a lot of, quote, good cholesterol. Again, no such thing as good cholesterol. But if you have high HDL and high myeloperoxidase, it's going to be due to your body having damaged HDL, and you keep pumping out more and more of it to try to replace the damaged stuff because of myeloperoxidase. The next one, Lp(a)2. This is also known as the plaque test, or PLAC. This is specific for plaque that's building up under the walls of the artery. So if this is elevated, your arteries are very much on fire, and you're 2 to 3 times, I think, likely or to have an event, meaning a heart attack or stroke, if this is persistently elevated. You have 60,000 miles of blood vessels, so it might not necessarily be in your coronary arteries. It might be in your carotid arteries, your iliac arteries, the arteries going into your legs. That could be plaque that's growing, essentially. But sometimes this can be up because if you have a lot of inflammation in your gum line. So if you have periodontal disease or gum disease, this is something that you need to get checked out by your dentist and get that taken care of, because I've seen it more times than I care to, that this is sky high red. Turns out they have something going on in their teeth. They get their teeth taken care of. This improves. The next one is ADMA, asymmetric dimethylarginine. This is a surrogate for how much nitric oxide your body can make. Nitric oxide is a gas that dilates your blood vessels, prevents stuff from sticking to the blood vessels, and makes your blood pressure improve. So things that tend to improve nitric oxide are exercise, green leafy vegetables, beets, and being outside in the sun, especially when there's UVA radiation, so which is the majority of the day. The next one, SDMA, is also somewhat of a marker of nitric oxide release, but SDMA is also a very good marker for kidney filtration. So if this is elevated, you have some issues with your kidneys, and that needs to get assessed. And then they don't have it in this inflammatory panel, but typically there's going to be a couple other markers called HS-CRP. That's a global marker of inflammation. It's a substance made in your liver. If it's chronically greater than 2, you got to kind of keep looking into what's driving it. Many times it can be lifestyle. So if you don't sleep well, you're eating poorly, you're not exercising, or you have sleep apnea, something that impairs your ability to recover, your inflammatory marker CRP will be elevated. But it's not specific. So it can be up if you've had a recent infection or a musculoskeletal injury. The other ones typically being the inflammatory panel are something called F2-isoprostanes. That's a urine test, measures your antioxidant defenses, basically tells you are you getting enough exercise, are you eating enough vegetables and fruits in your diet. And then there's sometimes an oxidized LDL. So if your LDL is getting oxidized, that's a problem. It means basically your cholesterol is getting rusted. So we'll transition down into the actual cholesterol profile. So sometimes it confusing topic, lipids / cholesterol. So I'll go to the basics where, every cell in your body needs cholesterol. So, Mother Nature did not put cholesterol into your system to give you a heart attack. Cholesterol is reparative. And you make your sex hormones out of it. You make your bile acids to digest your fats. You make the outer shells of your cells called the membranes from cholesterol. So it's not something bad. But if your body is inflamed and your cholesterol is getting damaged, it's a damaged cholesterol that tends to get stuck into your arteries. So in the traditional panel, it's these four numbers: cholesterol, HDL, triglycerides, and LDL. But again, there's no such thing as good cholesterol or bad cholesterol. There's just cholesterol and there's triglycerides. And cholesterol is a waxy substance that really does not float in the blood by itself. So it uses particles, which we'll show you in a minute. The particles wrap up the cholesterol and the triglycerides and transport it around the system. So total cholesterol, essentially a worthless test at this stage. This is like 1970s technology. If your total cholesterol is over 300, you might need to go looking into a familial issue. But otherwise, total cholesterol has zero bearing if you're about to have a heart attack or not. 50% of people come into the ER with heart attacks have, quote, normal cholesterol. HDL, again, there's no such thing as good cholesterol. There's just HDL that is functioning. And right now, there's not a great functioning HDL test. Myeloperoxidase is the best surrogate test for that. But HDL is somewhat of a composite of your lifestyle. So if you're exercising right, eating right, you typically have a higher HDL. There hasn't been a pharmaceutical drug or even supplements that raising HDL is shown to decrease your events, decreasing heart attack or stroke. So it's good to have a high HDL naturally. It's not proven yet if you raise it pharmaceutically or nutraceutically that you're doing much benefit. Triglycerides, basically your stored up sugars. So if you don't burn the sugar for energy, you'll package it up in the triglycerides to store for later. And you put the triglycerides either in your fat cells or it'll be floating around in your bloodstream, ready to be used for energy. So the only two numbers I typically will look at on traditional panels, the HDL and triglycerides. And you want to have a balance of less than 3-to-1. They'll do the division here, but if they don't divide it on your report, just divide the HDL and the triglycerides and get a ratio. You want it to be well less than 3. When it's less than 3, you're likely insulin sensitive, meaning you're not metabolically deranged where you're going to end up with prediabetes or diabetes. Your LDL-C, this is a test that you look at, but it's calculated. Most labs only calculate this. So there's something called the Friedewald equation where they're taking your cholesterol minus your HDL minus triglycerides divided by 5, and then they come out with this LDL calculation. It's only a rough estimate of what's actually inside the LDL particle numbers. And it does not always correlate well with the LDL particle number. So again, unless this number is 190 or greater than that, I'm not really concerned about it being a risk factor. I want to look at this LDL particle number. Another one of it could be something called ApoB, apolipoprotein B, very similar to LDL particle number and risk prediction. So sometimes you'll see it on both reports, but this one just has LDL particle number, LDLP. You can think of particles like cars. They fill up full of the cholesterol and triglyceride and drive it around the system. So the LDL particles take it from the liver, take it out to the cells and deliver the payload. The HDL particles pick it up, the cholesterol, and takes it back to the liver for recycling. A little bit simplistic, but that's about the best way to think about it in an easy way. But if particles are like cars, the cholesterols are the passenger. And so things that cause traffic jams are cars. It's not the number of people that are in the cars. So if you've had a heart attack, stroke, bypass surgery, and you're already a high risk individual, you would like to have your LDL particle number less than 1,000. Small LDL is secondary in risk. So LDL particles can either be small or they can be large. So if you think of your arteries as a tennis net, big fluffy LDL particles like a tennis ball are not getting through the net as easily as small dense LDL that would be like a golf ball. So if you have little golf ball particles, you're much more likely to get those things oxidized because they stick around in the system for about 5 days and just more risk that they get damaged. So small LDL can be genetically predetermined, but many times it's related to people developing insulin resistance or prediabetes. Again, this just marks that the LDL is small. The HDL particle number isn't really that great of a risk predictor. Typically, if you have a Lower HDL particle number, you're going to have a lower HDL-C. The size of the HDL matters in ways, but again, not a great risk predictor. But if you have bigger HDL, it's kind of like a dump truck. The bigger the dump truck, the more cargo it can take back to the liver. And then these VLDLs, very low density lipoproteins, these are basically precursors to triglycerides. So if you have very high VLDL, you're very likely to have high triglycerides. VLDLs go along with insulin resistance or metabolic syndrome. And then in most labs, they're going to have the hemoglobin A1C. This is essentially your 90-day average blood sugar. You would like to see your A1C 5.1 or less without medications or supplements. Once you start hitting 5.7, that's considered prediabetes. Over 6.4, that's considered diabetes. Typically, it's going to be 5 to 10 years of this creeping up before you become diabetic. But you have a 50-50 shot if you're pre-diabetic of going on to diabetes. If you go on to full diabetes, you've done significant damage to the beta cells in your pancreas, and it's much harder to reverse diabetes than it is pre-diabetes. And then on most Cleveland lab panels, they're going to always show this schematic, which I always do like to show patients. You know, they didn't do all the tests on this one, but typically, if everything is green down here, you're much less likely to have an event. If things are red, then you got to worry about what's going on. But the way I like to show patients is that this is the way you're born, and this is somebody who's had a heart attack, and it's progression. So first thing is that the artery will get inflamed and the walls start thickening. Soft plaque may be starting to be developing in the artery at this point. This is mainly if your LDL is oxidized or you have a lot of oxidation, which can be measured with the Z-test, prostate, and creatinine test. You're more at risk at the beginning stages of plaque can develop. This is the stage you also will be measuring with the CIMT scan, the carotid endomedial thickness scan. That's the ultrasound that we do in our office that can measure how thick this is. It's supposed to be a certain thickness as you age. If your arteries are thicker than your biologic age, then you're at higher risk and you want to do something about that. So if you're interested in the carotid scan, the CIMT is the abbreviation, just leave me a message below or call the office and speak to Cassidy. But after the artery starts getting more damaged, the plaque actually starts developing. And as long as there's not a lot of inflammation, the body will try to repair any damage and put a thicker cap over it, just kind of sandwich it into the wall of the artery so it doesn't cause any problems. These little white flecks are calcium. So calcium goes along with the soft plaque. So if you've gone off to have a CT coronary calcium score, it's basically counting up how much calcium is in the wall of the artery, which is a marker of how much likely soft plaque is there. So the higher the calcium score, the more plaque you likely have in your artery. When you have a lot of inflammation, especially LPPLA2 or myeloperoxidase, that tends to thin the cap out of the plaque. The plaque is like a pimple or a little volcano sitting on the wall of the artery. If the cap ruptures, all this damaged cholesterol and different components of the immune system leak out into the bloodstream. The body then sees that as a sign that it's bleeding and will form a blood clot. And the blood clot will seal off that damage, but that blood clot will also block all the nutrients and oxygen downstream. And if the blood flow doesn't resume, that tissue downstream dies. If the tissue dies in the heart, that is a heart attack. If it dies in the brain, that's a stroke. So you obviously want to get to the stages that if you have plaque, you're stabilizing the plaque. The first thing is go looking for it. So this is why I have patients go do the CIMT scan of their carotid or the calcium score of their heart if they've not had a stent, bypass, or angioplasty before. So this is the essentially the Cleveland Heart Lab panel, and now I'll show you what the new Boston Heart Lab panels are going to look like. I'm going to stop the share for one moment. All right. All right, so here's going to be the what the Boston Heart one looks like. So they do it a little bit differently. This is actually the report that the patients will get, and I have a copy of what it looks like right here. But it's over a 30-page summary, so it has all the traditional color coding of the traditional labs. But I do like this for the patients because it has more education for you. It'll actually explain a lot of the stuff that you'll hear me talking about, but you now have a resource to take home and take a look at. So I won't make you read all this with me, but I'll just kind of show you briefly kind of what everything looks like. But they're going to show what, the HDL, the LDL particles look like, what the cholesterol is really made of, that it's inflammation, scratching up the arteries. And when the arteries get, inflamed and scratch up, you're more likely to put plaque in it. You can do some genetic markers with Boston heart or Cleveland heart. Everything's color coded. So like I said, green is good, yellow is borderline, red's usually high risk depending on what it is. So here it is. The LDL initially gets trapped in the wall of the artery. And so it starts developing slowly and then usually can grow outward, but then it'll start growing inward. And only until it gets about 70% blocked, will somebody start having symptoms. Before that, you're likely to have no symptoms. But half the time people will have heart attacks had no symptoms until one of these little things pop. And so half the heart attacks happen with less than 50% blockage in the artery. So it'll explain more of what things, if it's yellow, red, or green in your traditional panel, what you should consider doing. So I will kind of skip through this briefly and then get to where the report is. And there's a lot of good stuff, and they'll look at some of your nutrition recommendations based off of you fill out there's a handout that comes with the lab form when you go to the lab. You fill out this lifestyle questionnaire, and then they'll somewhat look at your labs and come up with a suggestion of better foods for you. So this is always useful. This booklet also has all the different definitions. If I'm usually pretty good about translating science into action and science into something that is easier to understand. But even if I sometimes get caught using the medicalese language, this will break it down to exactly what we're talking about. And then this is what their panel is going to look like, similar to the the Cleveland and the Quest panel. Same story with the traditional panel. I'm really only looking at the HDL and triglycerides. On this example one, person's triglycerides are significantly elevated. Optimally, like to see your triglycerides under 80. So this person likely is going to have a component of insulin resistance. They have very high ApoB. ApoB again is very similar to LDL particle number, about 90% similar to that. So an ApoB over 80, you have high LDL particle numbers as well, high risk. This person actually has lipoprotein A or LP little a. 20% of the population has LP little a. It definitely increases the risk of heart attack and stroke. It's similar to LDL, but it's more atherogenic, more thrombogenic, meaning it's more likely to form plaque and it's more likely to form blood clots. It has a little corkscrew on it, so it's a little bit easier for it to dig into the walls of the artery. And again, it's genetically predetermined. There's not great medications or even supplements for lowering it at this time that have proven to lower risk. We know if you have it, you're definitely at increased risk. So you should try to fix all the inflammatory markers, make them normal, and try to get the LDL particle number under 1,000 if you have Lp(a). There's trials ongoing. It's probably 2-3 years away before it comes out. There's a pharmaceutical company making a monoclonal antibody, which will essentially significantly lower Lp(a). But if that study proves that lowering Lp(a) lowers heart attack risk or stroke risk, then there's more reason to try to actually treat it. Then on the Boston test, they actually do an HDL map, just basically the different sizes of the HDL. It's not a great risk predictor in my mind, so I'm personally probably not going to check this off unless the patient really wants it checked. But this is a good one, the cholesterol balance. So this will tell you if you're overproducing cholesterol or if you're over absorbing cholesterol. So, cholesterol, most of it is made in your body, made in the liver. And some of it obviously comes in through your diet, but not as much as people think. So once the cholesterol has been used by the body, it gets sent to the gut for elimination. There are certain receptors in the gut that do recycling, and they'll pull the cholesterol back into the system, send it back to the liver for another go around. So there's a prescription medication called ezetimibe, used to be known as Zetia. It blocks that receptor and will help lower the cholesterol in a pathway different than the way cholesterol is being made in the liver. So this is blocking the absorption. This part of the test will tell you, is Zetia probably a good medication for you? Would you get a likely significant benefit because you're a hyperabsorber of cholesterol? Their inflammatory tests are similar. This one has a CRP. This person's Lp(a)2 is slightly elevated, so I'd ask them to go get a dental evaluation. And if it's not a dental issue, then you just keep working on trying to lower that LDL particle number or the ApoB. They have high fibrinogen. Fibrinogen is a clotting factor. Blood's more sticky, your blood's more like ketchup, more risk of a stroke. So likely this person should be on aspirin if they have enough other risk factors and not a high risk of bleeding. The A1C, your 90-day average blood sugar. Then they use the A1C and insulin down here, 13. They have a calculation that gives you this HOMO-IR, which essentially is a composite number that will tell you what is your risk of developing prediabetes or diabetes. And then they do a couple of different genetic markers. I rarely check these clotting factors unless somebody has a history of a deep vein thrombosis or pulmonary embolism. Or if they're a woman who've had significant history of miscarriages, then I'll check the anticoagulation, the hypercoagulation profiles. But some of the genetic typing that they can do, I routinely check some patients with cholesterol issues is ApoE. You get one of these from your mom, one from a dad. A 3 and a 3 is normal. A 2 is protective from a heart standpoint. A 4 is likely higher risk for a heart attack or stroke. And the 4s tend not to tolerate high dose statins. They don't tend to tolerate high fat diets. So I actually saw a gentleman today, had an ApoE 4 and a 4. Only 1% of the population has that. He's not going to tolerate high dose statins. Mostly likely he would get myalgias or muscle pains if we started something too high. And the ApoE4s tend not to do well in the keto diet. They just don't have the fat transporters, and their cholesterol numbers go insanely high. And if they have inflammation, then that's like fire. The cholesterol gets damaged. They're much more prone to getting damage to their arteries at that point. So you should know your ApoE if you're on a statin or you're concerned about your risk of having side effects while on a statin. The other one that'll tell you what your risk of developing issues with on a statin is this one, SLC01B1. I don't always check it unless somebody's tried a couple of statins and said they had issues. Then I'll check it to see, and then usually tells you if you had issues. And I honestly usually pretty much always use pravastatin or rosuvastatin because they are the water soluble ones. They tend to cause less of the muscle aches and pains. So yeah, I'm usually already doing that even if I don't have the genes, but testing for that one. But if you have the gene, here it's you have up to almost a 5 times increased risk of developing muscle pains if you take the moderate to high dose statins. So I think that's it for with the Boston Heart Panel. Well, sorry, some more. So this is basically their omega check or their omega-3 panel. So, but it's even more comprehensive because it's looking at all the different fatty acids. So mainly on this one, we look at the trans fatty acids. So this is like the margarine and the really deep fried foods. If this is high, you really need to reassess what you're putting into your system. High trans fats, definitely bad for the arteries. Monounsaturated fats, this is basically the olive oils and avocados. You don't want to be low on this. The omega-3 index, their range is a little bit different than the Quest one. Usually Quest ones are 5.5%, but higher the better for people who have cardiovascular disease, especially if they have arrhythmias or hypertension. Usually want it to be at the upper range of normal or higher. Then I usually also look at the omega-6 to omega-3 ratio. The omega-6s tend to be the vegetable oils, the corn, soybean, and such. The 3s are the cold water fish. This must have a little bit different reference range than I'm used to looking at, because usually you want this ratio about 4 to 1. Here they're saying less than 15 is normal, but typically I see patients in 15 to 20 range. If they're not eating a lot of seafood or they're eating a highly processed standard American diet. Then this is part of the regular chemistry panel. So this person's liver function looks okay. Creatine kinase is a muscle protein. Don't routinely check unless people have issues with muscle pains on statins and you want to see what this number is. But if this is slightly elevated, it's not likely due to the statin. It's when this thing significantly rockets up that you're at risk while you're on the statin. NT-proBNP is a substance made in the heart. Essentially when it's under stress, it releases this substance to basically try to diurese or get off fluid from the system. So this is a good marker if somebody has a weakened heart, congestive heart failure, or they have atrial fibrillation, abnormal heart rhythms. this will tend to be higher if they're about to have an exacerbation. So it's also a good test that to have a baseline when you're feeling quote normal, because if your normal is 200, this is the test we typically would use in the ER when somebody presented with shortness of breath. So sometimes shortness of breath is a little bit hard to figure out what's driving it. If this is low, it's unlikely to be the heart. It's more likely to be a lung issue. If it's really high, it's more likely your heart than it is lungs. This person's kidney function was okay. And then albumin is a protein. You want to have normal protein to transport your hormones. But this person has low vitamin D. Vitamin D is an extremely important hormone for your immune system. The heart cells have vitamin D. If you don't have enough vitamin D made naturally with sun hitting your skin, you're much more likely to catch viruses. You're much more likely to have high blood pressure. You're much more likely to have coronary artery disease. There is not yet data that if you supplement somebody with a pill, that you're necessarily going to lower their risk. So, this is what's best done when you go outside in the sun. So, homocysteine is normal. Homocysteine is an amino acid that when it's high tends to cause the blood to be more sticky, cloudy. Also tends to calcify the coronary arteries. Some people have a genetic abnormality, one of the MTHFR mutations. Generally, it's the C677T mutation that actually might be more of an issue. If you have that gene mutation, you'll have potentially higher levels of homocysteine, and you may not be able to convert it into methionine effectively. So those are people that sometimes will take methylated B vitamins and methylated folate to change homocysteine levels back to normal. And uric acid, people think of it as a lab for gout. It's also a good marker for metabolic syndrome. So if you have high uric acid, you're more prone to becoming pre-diabetic. And then the rest is just a summary. So I'm going to stop the share here, and then I'm actually going to stop recording for a moment, and then I will open it up to questions. And